So, who is the right candidate for active surveillance once diagnosed with prostate cancer? And in those who actually need medical treatment, what's the right treatment approach? How do you know? How do you choose? How do you know that, hey, maybe prostate surgery versus radiation with hormone deprivation therapy? Well, my next guest is Dr. Matthew Cooperberg, who is faculty at the University of California, San Francisco, UCSF. And his clinical interest includes early detection, diagnosis, and management of different genital urinary malignancies, primarily prostate cancer, and in minimally invasive techniques to treat benign and malignant diseases. He performs robotic, laparoscopic, endoscopic, and percutaneous surgeries and is interested in incorporating promising new technology into his practice. His particular interest is in risk stratification of prostate cancer and other tumors that are matching treatments appropriately to those with patients most likely to benefit using novel imaging tests and biomarkers together with clinical information. Dr. Cooperberg is a fellow of the American College of Surgeons and a member of the American College of Urological Association, the AUA. Lastly, he was mentored and recruited as a faculty member by the one and only Dr. Peter Carroll back in 2009, who I certainly hope to have Dr. Carroll on soon. Dr. Cooperberg uses a variety of genetic tools and genetic tests to determine who determines what. And he has a pretty interesting approach. He definitely is a big fan of active surveillance. And you're going to love this conversation with Dr. Cooperberg from the University of California of San Francisco, UCSF. Please enjoy this conversation with really one of the luminaries in prostate cancer, Dr. Matthew Cooperberg. Let's go. Before I proceed, I just want to clarify that this podcast and all Dr. Geo content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Now, please join me. Geo, as always, it's my intention to help you optimize your prostate health, things like testosterone, erections, and how can we live better as we age as men. Today's my pleasure to have Dr. Matt Cooperberg from UCSF. Matt, I'm eternally appreciative of you being on. Really know your schedule to some degree, but I know it's busy. And when guys like you say, yeah, I'll be on and actually make it, it's just such an honor. So thank you so much.
It's a pleasure. Thanks for having me on.
Matt, prostate cancer. I mean, look, you write a lot. The fact you publish a lot of very interesting papers in peer-reviewed journals. So I think the way we want to take this is I like to know your process in terms of both diagnostics. You know, anyone who's heard my podcast before, they've heard me say over and over again, I never wake up in the morning and say, man, I can't wait to have a prostate biopsy. Right. And I think that's reflective of most men, including urologists. I always wonder how many urologists have gotten a biopsy. I don't know if that has been, those, particularly those in urologic oncology. So then we want to biopsy only those that we think should get biopsied. Yep. What is your process to determine that? And we know the issues with PSA. I think my audience is versed with that. I let me just say this. I think the PSA is an important tool. It's not the end all be all. I've heard Ted Schaefer say, look, less than 10% of the population has a high PSA in the world. So it's something. And I think when you look at velocity, PSA density, there's a lot of value there, for example, and even absolute value. If a patient is coming in with a PSA of 100, you have prostate cancer. It's likely advanced prostate cancer, period, end of story. So there is some value there. So that's just so that you know where I'm coming from. I'm not a PSA hater at all. There are people think that, well, no PSA ever, and I don't agree with that. What is your process? Patient comes in, regardless of age here for a second, they come in, they have a certain PSA. What is your process to determine, yep, you need a biopsy, or look, you don't need one?
Well, actually, let's start with PSA because that's where the biopsy discussion starts. I mean, my feeling is PSA is the best biomarker we've ever had in the history of oncology. We just haven't used it very well historically. We tended to overscreen older men. We tend to underscreen younger men. We've overdiagnosed and overtreated low-risk prostate cancer, and we've underdiagnosed and undertreated high-risk prostate cancer. Despite all that, we drove the mortality rates down 50%, which is a huge victory. But it wasn't done very well. And so I think it's becoming increasingly clear that the best way to screen and diagnose prostate cancer is to look in younger men. So midlife, sort of mid 40s to mid 50s, is the best time to get a baseline PSA. Now that baseline should really be under 1. This 4.0 number is still kind of out there in the world, and most primary care doctors think about that when they decide whether or not to chase down a PSA and send the patient to see urologist in the first place. But 4.0 is really kind of yesterday's news. In midlife, it should be under 1. The median across the whole population at age 45 is about 0.7, 0.8 by the time you get to 50. By the time you get to 60, it's about 1.0. And when you screen a guy in this age range, 75% of the population is done with the PSA, and they're done for 10 plus years. We've got some great studies suggesting this. So it's a fantastic first screen when we use it to rule out, not to rule in. We're trying to, that first PSA test is great at telling us who doesn't have prostate cancer. And again, that's 3/4 of the population. It doesn't tell us.
Interesting point, just because it used to be that it was more to rule in than to rule out. So it's how
Exactly.
you use it, to your point.
Exactly.
Yeah.
It's how you use it. So I really have started to think about this as the first test with a good negative predictive value if it's under 1, meaning if your test is under 1, you're in good shape for many years to come. If it's over 1, it very likely doesn't mean very much, but it might. Okay. And certainly as you get into higher values, we get more and more worried. But to your point, no, nobody wants to rush in for biopsy. So we are in an era now where we have a number of secondary tests that we can use to try to figure out which men with an elevated PSA actually need to be concerned about prostate cancer and get a biopsy done. So in that category.
Before you continue on that,
go
I
ahead.
definitely want to know about that. I'm sometimes accused, and maybe rightly so. I'm a sucker for data. Just more is better, and some people say no, more is not better. Less is more, right?
Yes. Yeah.
So, for example, 40-year-old guy, why not have his father had prostate cancer? I don't know, at 60. Why not 40 years old? At least how many? I don't know if you're seeing this. 45, 46, 47, aggressive prostate cancer. You see this in your office. So why not at 40? And I know the guidelines, but those are guidelines to guide us.
Yeah.
Why not at 40?
Actually, most of the guidelines do now say if there's risk factors like family history, think about starting at 40. So most of the guidelines now, with the exception, with the elephant in the room, is the U.S. Preventative Services Task Force, which is the one that most primary care docs listen to. They're revising their guideline. Hopefully they're going to change things. But every other major guideline, including the AUA's new one last year from Den Lin and John Wei, it's probably the best one out there currently, in my opinion, that recommends starting at 45 or at 40 if there are risk factors. So Black or African American race, family history, any kind of genetic predisposition, you should get a baseline of 40. And that's exactly the recommendation. Now, family history is a moving target. Everybody has an uncle or a grandfather that had prostate cancer when they were older. Maybe it wasn't treated. Somebody who had relatives diagnosed younger, somebody actually died of prostate cancer in the family. These are close relatives. If it's situations like that, then absolutely start at 40.
What's the age for the relative that? So I'm thinking, younger 60, 65, they develop prostate cancer. What's the age that you go by?
Yeah, that's about right. And again, though, the details matter. So diagnosed, under 60 with, a speck of Gleason 3-3, we don't worry so much. Diagnosed under 60 with a Gleason 9 and they wound up on, hormonal therapy 3 years later, that's a very different story.
Breast cancer from a maternal?
Yeah. So women in the family with breast and ovarian cancer. So, this gets into the genetics conversation. Prostate, breast, and ovarian all tend to track in families where there are mutations in genes like BRCA1 and 2. There's a few others in that cluster as well. So absolutely, families where we see a lot of breast and ovarian, we do think about elevated risk as well. And there is the one caveat anytime we talk about family history is there are plenty of men who just don't have a lot of male relatives. They don't have brothers, they don't have male cousins and uncles and things.
They were adopted.
So they could have been adopted, exactly. Maybe they didn't really know their dad. There's plenty of those situations. And so, if you know this family history is strong family history of prostate cancer, that's a warning sign. But just because there is no family history does not necessarily mean that we don't have to worry about genetics.
Excellent. All right. So we have the PSA conversation. What's next? What else can we use? Dr. Cooperberg, I don't want to, if everything indicates, yep, you need a biopsy, I would do it, but I don't want one. What else is there?
Yeah. So, if the PSA is sky high, we go right to biopsy, but that's pretty uncommon these days. Most men with an elevated PSA, especially coming in this marginal elevation range, we think about secondary testing. So that is either blood or urine tests or imaging, or sometimes both. So in lots of parts of the world now, if you have an elevated PSA, you get an MRI. If the MRI is negative, you don't get a biopsy if the MRI does not show us a lesion. That is not typically our first reflex test here, partly because MRI is about 10 times as expensive in the US as it is in every other part of the developed world for reasons that have a lot to do with our healthcare system and nothing to do with the actual cost of doing an MRI scan.
I'll have you back to talk about that some other time.
We can talk about that too. Electricity is not more expensive here than everywhere else. This is just the way our system is set up. But the bigger problem is that the interpretation of MRI is very center dependent and radiologist dependent, and we know there's a lot of variation from place to place. So the MRIs really have to be done at centers of excellence where the radiologists do a ton of MR reads. So we use MRI very heavily.
Reads specific to the prostate.
Specific to the prostate. The radiologist who reads,
that's a big thing.
I
have recorded, hopefully published soon, Dr. Daniel Margolis, who is from Cornell. Awesome. He was amazing.
He's awesome.
And so they are developing certifications for prostate specific.
Yep.
But it's not required and I'm not sure if that process has started yet. So yeah, that's such a critical point because you're only going to go by the information. I mean, how comfortable are you? For example, some guys at my institution, Tunisia, Wysock, they go by what the radiologists say, but they know what they're looking for. I mean, like, look, there's something here, and then they get is that how you work in your practice? Like you can see the images and you kind of have an idea, then you verify it? Absolutely.
And Tunisia, Samir was a trailblazer in this, but I think a lot of us are in a similar model, which is kind of trust but verify. We have very good radiologists who we rely on, but we all, everybody that does this well, we all learn to read the MRs ourselves, and sometimes we will find things that were missed or we'll disagree with calls. Look, there was a nice study out of Stanford from Jeff Son a couple of years ago at Stanford University, which is a very good prostate center. They don't have quite our volume at UCSF, but very good level 1, top tier prostate center. They looked at the likelihood of having a high grade prostate cancer if you were called a PIRADS 5, so the kind of top score on the MRI. And that ranged from 40% to 80%, depending on which Stanford University radiologist happened to pull your scan off the queue on a Thursday morning. Okay, that's crazy variation. There was another paper from Antonio Westphalen, again, a couple of years ago, looking at 25 major centers across North America. Again, the likelihood that there was a meaningful cancer there, if they called it a high grade, PIRADS 4 or 5 on the MRI, ranged from 25% to 75%, center to center, across these major centers of excellence for prostate cancer. This does not even get into the problem of the community radiologist who's looking at mammograms in the morning and maybe a couple chest X-rays and then picks up a prostate MR twice a week, on a again Thursday afternoon, which happens very, very commonly.
And I think it's very important as clinicians, right? And in my world, I do the same where I say, okay, Geo, where's your bias? Okay, I'm biased here. Okay, I need to be less biased and more objective about X, whatever the approach, the supplements, even the lifestyle, even the diet,
Sure.
plant-based or this. Okay, I know I have biases there where, it's all about the patient. I'm also biased about people going to high academic institutions, and I work in one, right? So you work in one.
Yep.
Because I see what happens at Grand Rounds is always trying to get it right. All these meetings to try to get it right and perfect it.
Yep.
And am I wrong? I mean, and I know that not everybody has access to high academic institutions, but am I wrong to say, hey, no, go to this place because this is a high level academic institution? Or is that part of what you think it's the deal as well?
Look, obviously, I have the exact same bias coming from
Right,
the
right.
UCSF Cancer Center. Prostate cancer is what we eat, breathe, live, and sleep. I mean, it's what we do all day, every day. We write, hundreds of papers on the topic, everything from how people make decisions down to how the molecules work to how the healthcare systems work in different countries, taking care of prostate cancer. I mean, everything there is to study about it, we study. We're constantly trying to do things better. And this is what we do as opposed to taking care of kidney stones in the morning and, BPH in the afternoon and prostate cancer once or twice a week. So yeah, I think this care and prostate cancer is rarely an emergency. And in the era of telehealth, we can talk to people anywhere. They don't have to drive 6 hours from wherever it is they live. So I think the vast majority of this management should be happening in centers of excellence. It does not have to be academic centers. Some of these very large urology groups that have coalesced have really subspecialized, and they have, they're not attached to academic centers, but they have a few of the urologists in the group who are designated. You're the prostate cancer people. They're often fellowship trained. They're up on the literature. They're very good at surgery. They know all the medications and all the markers, and they do just as good of a job as those of us in academia. So it doesn't have to be an academic center, but it really should be a center of excellence where prostate cancer is the focus of the practice.
Yeah. Secondary tests. So we spoke about
Yeah,
MRI.
so let's get to that. Yeah. So MR is a big one, but honestly, in our practice, before we get to MR, we often use these liquid tests. So there are blood and urine tests, which are much more closely validated to predict high-grade prostate cancer. And that's a really important point to make here, is that everything we're doing here, both MRI and all the liquid tests, the goal is not find prostate cancer. If you live long enough, every man gets a few cancer cells in the prostate that we could find on autopsy. We're interested in the so-called clinically significant ones, which are defined as a Gleason grade group 2 or higher. And a lot of those are not that significant either, but that's where the cut point is currently. We know that grade group 1 basically has zero capacity to spread. It might get worse over time, but with all these secondary tests, we're saying if there's a grade group 1 there, we're perfectly comfortable not knowing about it. So
I'm guessing that you're on the Egner camp on this.
very much. Scott and I have written papers on this. Yeah, very much so.
Let's not call it cancer.
Don't call it cancer. It doesn't.
Right.
It doesn't. It looks like a duck, but it doesn't quack, talk, or smell like a duck. It's not a duck. It's a grade group 1 should be thought of as a precursor lesion. We have to follow it. We do active surveillance. Someday, if you have grade group 1, we might find higher grade disease that we need to treat. But grade group 1 does not have the molecular or the clinical characteristics of cancer. So why are we calling it cancer?
Our next amazing sponsor is XY Wellness, a company I know a little bit about as co-founder and medical director of the company. XY Wellness is a company to help men renew, rebuild, and reclaim their health, their bodies, after a prostate cancer diagnosis. XY Wellness is a lifestyle company that helps provide a no-nonsense roadmap to health and wellness in men after they are diagnosed with prostate cancer. The hope with our program and what we see with many of our members is that men after prostate cancer tend to thrive, not only survive, through our program. To learn more about XY Wellness and its roadmap, please visit the link below in the show note.
Okay, and specifically to that point, the reason it's germane right here is that all the blood tests that we have, so we have 4K, we have Phi, which are both blood tests looking at different subtypes of PSA. And then in the urine, we've got Select MBX, we've got ExoDX, we've got the My Prostate score, which now has a version 2. There's Stockholm 3. There's a whole, that's blood. That's another blood test hitting the pipeline soon. We've got all these tests which are specifically designed to tell the patient what is your risk of having a high-grade prostate cancer, grade group 2 or higher. So if the test is positive, I don't believe, we don't have great data that any one of them is better than another. We have used a lot of ExoDX in the COVID and forward era because it does not require a DRE. So most of the urine tests that are out there, you have to do a finger exam of the prostate first to push a little prostatic fluid into the urine. ExoDX, because it's looking at exosomes, which are these secreted little vesicles containing RNA. They don't require the DRE first, so you just send the patient a kit at home, pees in the cup, sends it back to the lab. And
Easy.
that was released in like June of 2020. It was incredibly fortuitous for the company. So it became a really easy go-to because the patient doesn't even have to go into a lab anywhere to get the test done. So that kind of became a go-to for practicalities more than saying it is a better test necessarily. The My Prostate score just came out with a version 2, literally just published a month or two ago in JAMA Oncology with very good performance characteristics. They've gone from 2 genes to 18 in the urine with a bump in accuracy. So that's one to keep an eye on. We do a fair amount of 4K testing as well. I've always liked the report formatting for that one. So we use different tests. Probably EXO more than anything else for practicalities.
So my issue with 4K or
Yeah.
any test, well, I have not utilized Phi or any other.
Yep.
I've only
Yep.
utilized 4K and
Yep.
ExoDX. My issue with 4K, if we're saying that we can't really bank on PSA, but PSA or the Callicrin 2, which is PSA, is part of that equation. So if I see a guy with a PSA of 15, but it's likely BPH based on PSA density, MRI, and other things, that 4K oftentimes does come up higher. That number, the value comes up higher oftentimes. So I think that's an issue. I don't know if that's the case with Phi as well or any of the others, but that seems to be an issue with the 4K. What are your thoughts on that?
Yeah, I think there's a lot of subtleties and there's a lot of art of medicine with this. And it's part of the reason I don't have a single answer to say this is my favorite marker. It depends on the situation. If it's a guy with BPH, first of all, I'm much more likely to get, based on symptoms or based on, digital exam, much more likely to get MRI early to get a volume of the prostate so that we can look at the PSA. For African-American men, I worry a little bit about the ExoDX test as well as the original version of My Prostate score, because one of the key driver genes there is the TMPRSS2 ERG fusion, which is much less commonly present in Black men with prostate cancer compared to white men. As you say, if we're worried about BPH, then both of the blood tests may be a little bit less reliable when we think about the urine tests, which are looking at other genes not related to prostate volume. So there's a lot of subtleties in terms of how we pick these tests, honestly, and how we combine them.
Pause there for a second.
And I should say too about MRI, like I often come across as kind of bashing MR. We get a ton of MR. I almost never do a biopsy without having an MRI first. But my point on MR is I prefer the liquid tests as the reflex test, as the kind of secondary screen over MR.
Perfect world. I another, where I try to be honest about myself and like the Jews would say, my own mishigas. I don't think cost. I know that maybe I should. So I just want the best information for my patients and let somebody else figure it out if they're going to figure it out. So to me, it's like everybody MRI, everybody one of these tests, particularly in my view, a non-PSA type of test. And that will, because once again, if what you want is data as the patient, these two things, I'm also very interested in their PSA density that you could get from the volume of their prostate. Nothing better than an MRI in that regard as well.
Yeah, totally agree.
Repeat something you said that I'm not sure that my audience knows. African American men, the reason why ExoDX test and maybe even my prostate score is not a good, not the best tool is why.
Well, we don't actually know. So it's an open question. So there is a gene fusion called TMPRSS2 ERG, which is one of the hallmarks of cancer is that the genes get dysregulated. And it is important, by the way, just to step back for a second and talk about genetics, because we're using a lot of genetic testing these days. And we use different terms, genetics and genomics, which are actually mean different things. The way we use them these days in healthcare, it's all about genes, but the way the terms have evolved is that when we talk about genetics, we're usually talking about germline testing, meaning the DNA that you got from your parents. And when we talked before about the BRCA1 and 2 and who is at elevated risk because of their family history, that is germline genetics. So you get the same DNA in every cell in your body that you got half from your mom, half from your dad. And there may be certain variations or mutations in certain genes that set you up to be a higher risk for developing certain cancers as you go through life. And, that's why for people who do have strong family histories or where we know some of these genes may be circulating in the family, we think about earlier testing. We think about more intensive genetic testing. Then there's genomics, which is looking at how the genes are altered in the cancer. So again, you get the same DNA from both your parents, same DNA in every cell in the body. The DNA is broken up into 30,000 odd genes, and the way those genes are regulated defines, well, that's a prostate cell, that's a heart cell, that's a bone cell, that's a brain cell. And the key hallmark of cancer is genetic dysregulation, meaning you've got growth switches, growth genes that are on when they should be off. You've got regulatory genes that are off when they should be on. We can start to count these mutations and get a sense of cancer prognosis. But we also know very specific things that happen very commonly in certain cancers. So one of them in prostate cancer is that one of the ways genes can get sort of screwed up in the course of cancer genesis, development of cancer, is you get rearrangements and fusions of genes. And one of the things that happens very commonly in prostate cancer is you get a fusion of ERG, which is a kind of master regulatory transcription factor. ERG regulates expression of lots of other genes, and that gets hooked up to TMPRSS2, which is a promoter. It's a response element for testosterone. So basically what happens in the cell is you put a whole bunch of cell development and cell growth pathways under control of testosterone, which would not normally be under control of testosterone. So now a cell which is seeing a lot of testosterone, which is always the case in an untreated prostate, you're getting a lot of unchecked, driver of growth signals. And that is often one of the first things that happens in prostate cancer. It's called a TMPRSS2 ERG rearrangement. And for whatever reason, this is not well understood. We see that very commonly, about half of all lower grade, lower stage prostate cancers in white men, and much less commonly in black men. Again, the reason for that is not really all that well understood. But the fact is that two of these urine tests are looking at TMPRSS2 ERG, that fusion gene in the urine. So it's an open question. It has not been studied one way or another. It is not clear if these tests are going to perform as well in black men as in white men. Some of the tests have been well validated in diverse populations, others have not. But it's a specific concern, at least a theoretical concern, for EXO and for, again, version 1 of MPS, because those include this fusion as one of the key driver genes.
Thank you for that. Appreciate it. So then the other tests that pre-diagnosis that I want to know, particularly if the PSA is, I don't know, high, depending on age or whatever, but high, 15, and we think all the indicators are saying, yep, it needs a biopsy. I would like to know a PSMA scan just to make sure that, again, I'm not thinking cost, right? So I'm just not thinking cost. Let me get all the data in front. We know what we have. And then if they get a treatment for their cancer and then a rising PSA, later on, we have a baseline to compare PSA PET scan so that we know, oh, yep, you didn't have it here, you have it here. And I know that insurance won't pay. I know the issues. The insurance won't pay for it. Sometimes patients say, okay, out of pocket. If they could, they'll pay for it. Maybe they will at some point. Your thoughts on that thinking, again, putting cost aside?
Yeah, that's in evolution. There's a lot of interest in PSMA as a diagnostic modality for primary tumors. For anybody that's not familiar, PSMA is our new gold standard for the last few years for staging prostate cancer, for looking for metastatic disease in lymph nodes or bones or elsewhere in the body. We use it very commonly for men with high-risk cancers looking for metastatic disease. It's better, probably 10x better than a bone scan or an old-fashioned CT would have been. We also use it for men who have recurrence after surgery or radiation therapy. Using it, before the diagnostic biopsy is still in, I'd say, research phase. There are a number of interesting studies suggesting it might be just as good as MR, maybe even better than MR. It can also be combined with MR. We can do a PET MRI scan, but these are definitely still sort of research studies. It is not out there as a real diagnostic yet. I think that's going to change in the next few years. Can you get one done out of pocket? Probably. I think it's about $9,000 to pay for a PET scan cash.
Which is,
so it's
not reasonable
it's a lot.
for many people.
I wouldn't recommend spending that kind of money in an era where we have lots of other good tests. The one exception is, the times that we are chasing down a PSA that just keeps going up, and we've done a couple biopsies, nothing's making sense. MR is not answering the question. The other markers are equivocal. Once in a while we'll try to get one done in that scenario, but that's pretty rare. A good quality MRI today, read by a radiologist in a center of excellence, gets us pretty far down the track.
Okay. They get the biopsy, so all indications, all indicators are suggesting, yep, he needs a biopsy. rectal,
Oh
transperineal.
yeah,
Where are
sure,
you
sure.
going with this?
Yeah. So there's another great evolving area. There's a lot of interest in transperineal biopsy, a lot of marketing around transperineal biopsy right now. I think this is going to, I think transperineal biopsy is here to stay as an alternative. I don't think transrectal is going anywhere anytime soon.
Hmm.
This has been driven by concerns about infection rates, obviously. And yes, when you do transrectal biopsy, we're going through the rectum, which is a contaminated space by definition, and infections do happen. They can be serious when they happen. But we are finally starting to see actual randomized controlled trial data coming out. There was a study updated at the AUA. There's an even larger study coming out of the UK. And these are not showing statistically significantly different outcomes between transrectal and transperineal. So the difference in terms of infection rates is there, but it's subtle. And I will say transperineal is for sure a lot more uncomfortable. It takes longer. Now, my disclosure is I've done a handful. I'm not a high volume transperineal person yet. I've not hitching my horse to that wagon at a gallop. I've done some, and I'm sure I'm slower because I've only done some of them. But even talking to patients that have had these done in high volume centers where they do a lot of transperineal, when they come back to me and we do a transrectal, universally they say the transrectal was much more comfortable, much less pain in the
Wow.
short
Okay.
term. And the trials have borne that out.
I would think the opposite, right? Rod in your rectum,
Well, don't forget, you still need the ultrasound. You still need, a transperineal biopsy is still guided by a transrectal ultrasound. So you still have the ultrasound probe in there. And there are some men where that is the most uncomfortable part, is just having the ultrasound probe in the rectum. So that's there either way.
needle going through the rectum.
The needle
I'm
going
thinking
through the
needle going through
rectum,
the rectum. I'm thinking, I don't know. I've read so much on microbiome and antibiotics. I just
yep.
don't want any antibiotics in my system unless I absolutely need it. So that's
Yeah,
another element of it.
there is, and that argument about antibiotic stewardship comes up among the pro transperineal advocates out there. I would say the 2 doses, the 1 day of antibiotics that we're now giving as a prophylactic in the spectrum of antibiotic overuse in the healthcare system are kind of small potatoes, honestly. It's not nothing, but it's not in the spectrum of areas of antibiotic overuse.
Mhm.
It doesn't strike me as a major one. I like at the end of the day, I think transperineal is a great addition to the toolkit. And we are, like I said, we're starting to do them. I think for anterior tumors, it makes a lot of sense. I think there are a lot of situations where it makes more sense, but I don't see it wholesale replacing transrectal based on the data that are coming out from these large trials. Now that may change with the big one coming out of the UK. But the thing with the biopsies, first of all, we don't want to do a biopsy unless we need to. We don't want to do a biopsy unless we're pretty sure we're going to find something that we have to find.
Yeah.
So the secondary testing, the whole goal is to not do biopsies. As imaging gets better, our hope is that we can eventually start targeting lesions only and not, do the systematic biopsy of the prostate. I don't think we're there yet, but we're hopefully heading in that direction. So, the goal is to do fewer biopsies, but the last thing we want is for the biopsy to be so uncomfortable that it's a barrier to active surveillance, because we do hear this from time to time. Men who are diagnosed with a low-grade cancer, grade group 1, who should absolutely be on surveillance, or even a low-volume grade group 2, who can absolutely be on surveillance. We don't want men in that category to say, listen, I'd rather just get my prostate out than ever go through another biopsy because that was such a horrible experience. And we see that. I still see that today. I mean, I still have colleagues around the state in California that don't give anesthesia, which is barbaric, or they gave anesthesia, but they don't really know how to give a good anesthetic. So, patient was suffering through every click of the biopsy gun.
There again, I never see these issues occur again in academic institutions.
Correct.
And not to say that in
Correct.
non-academic institutions it occurs all the time. No, there are great people out there, but when you hear these results, these uncomfortable biopsy situations, it occurs more often in non-academic institutions.
Yeah.
So
Yeah.
there again, I'm just saying.
Oh,
And
I agree.
I don't do biopsy, so I have no
I agree
axe to grind
completely.
here.
Yeah.
I've been So it used to be that in this particular situation with needles going into my prostate or into a prostate from the rectum or the perineal, it used to be that I say, yeah, less is more, 12 cores, not more. But
Yeah.
man, then I see a patient with a 25 core biopsy.
Yeah.
And then is like, I feel more, patient on active surveillance, 25 core biopsy, Gleason 6, MRI guided biopsy,
Yeah.
decipher low risk. I'm like, okay, I'm not going to this patient, I'm not, because they're following my suggestions so they have better conversations to you. So I'm kind of
Mm-hmm.
helping them through. And I'm like, this situation, I'm pretty, the fear there is that, okay, do I have everything? What if I'm
Yeah.
missing something? Well,
Yeah.
I fear that less if it's a 20 core. I can't even believe I'm saying that because I was always no, less is more. 20,
Yeah.
25 core biopsy, MRI guided, this, low genomic score.
Yeah.
I feel really good about we know what we know on this patient. Maybe in 5 years, unless something changes, we don't need to rebiopsy. Your thoughts on that?
Yeah, I think that the number of cores is less important than how thorough the sampling was, right? So our typical practice now is I'm a big advocate for the confirmatory biopsy. So if somebody gets a diagnostic biopsy, they come in to see us, especially if we didn't do that diagnostic biopsy, we will almost always repeat one within a year with an MRI ahead of time. We will do typically 2 cores, give or take, of each spot that we see on the MRI. And then a systematic biopsy, and our hands is 14 cores sampling the different areas of the prostate. So yeah, that can add up. If there's multiple lesions on the MR, that can add up to 18 to 20. If it's a really big prostate, sometimes it takes a few extra cores to sample it adequately. But yeah, once we've got that confirmatory one under our belts, we really don't want to do another one for a while if we don't need to. Decipher can be helpful. I don't get a Decipher in everybody if they have low risk disease, but it is definitely the genomic test that we use most often for men who are borderline. If they've got a high volume grade group 1, they've got any volume of grade group 2, if they're young, if there's anything that's kind of a risk factor, Decipher is a fantastic piece of information that helps us guide kind of downstream decision making. But once we have that second biopsy, then the goal is to follow them with PSA and MRI as long as we can, and try to avoid having to do multiple biopsies down the track. There's a lot of interest in whether we can skip all the systematic cores downstream as well and just focus on the tumor itself. Again, the current state of the art with MRI, we're probably not quite there, but I think we're heading in that direction pretty quickly.
So you
So because
mentioned,
the goal is to do fewer biopsies.
yeah, of course. I just, if you have to go through it, I'm thinking, I just want a good one. I want the best one. I want MRI guide, MRI, targeted biopsy. I just want a good one and not have to think, oh my God, it's, is there something missing? Am I going to have a recurrence? They go to these support meetings, right? And somebody say, yeah, I was in active surveillance, and but then later on they found a Gleason 7 or Gleason 8, and the question is always, was that there in the beginning, or that came about later on. Genomics, there are a few. Can you break that down for us in terms of
Sure.
For biopsy tissue itself?
Yeah. So we just mentioned Decipher. So, again, as I said before, genomics, when we say genomics, we're talking about alterations in the genes and the way the genes are regulated in the cancer tissue itself. So the tests which we've had available for about 10 years now, actually a little more than 10 years, we've got 3 of them. There's the Oncotype test, there's Polaris, and there's Decipher. And then also in this space now is a pathology AI tool called Artera, which is not a genomic test, but it's trying to do similar goals, which is do a better job with prognosis. Break down these risk groups that we have and say which cancers are more or less likely to progress, to do badly as time goes on. The 3 genomic tests all have kind of multiple validation studies behind them. I would say the evidence behind Decipher far, surpasses any of the other tests in terms of the, dozens and dozens and dozens of studies which have been published over the last 10 years, looking at outcomes ranging from, what's the likelihood of finding worse disease if we went to surgery, to what's the likelihood of recurrence or metastasis, actually dying of prostate cancer after surgery, after radiation therapy. They have a huge, huge volume of evidence behind it now. The other reason that I tend to use Decipher is we get a lot more information out of the actual test. So the first 2 that I mentioned, Polaris and Oncotype, are both doing something called RT-PCR. So they have sets of genes which are well established to track with cancer outcomes. The Polaris test is looking at a set of genes all related to cell cycle progression, how fast the cells are dividing, how fast the cells are trying to grow. The Oncotype test is looking at 4 different pathways, 12 genes across those 4 pathways. But when you run the test, you really just get the score based on those fixed sets of genes. Decipher has always been playing the long game. They struggled early on as a company because their technology was a lot more expensive and a lot more cumbersome, but it also has a lot more value in it. They are running an affymetrix array on every clinical specimen they get, and that is looking at expression across the entire genome. So all 30,000 genes, they are getting the information about up and down regulation of those genes. So the Decipher score is calculated based on 22 genes, but they have the data on the entire genome. And, they share that with academic collaborators like us at UCSF, but it also allows them to do other things that are currently in progress, like trying to predict response to different treatments. And that gets us from prognostic testing to predictive testing. Prognostics is where we've been for the last 10 years, which is to say, all right, look, we've got a cancer that is intermediate risk by NCCN. We can do a better job breaking down that risk classification with tools like the CAPRA score or a nomogram, or there's one called StarCap. We can add PSA density. We can look at the extent of pattern 4. We can look at the subtype of pattern 4 under the microscope. These are all things that we can do for free with the information on the chart to try to break down that intermediate risk category better than like the NCCN or AUA risk groups. But then we can bring in a genomic test and do still better in trying to really pinpoint, well, this is going to be a bad actor. This one is not. This is the bird versus the rabbit versus the turtle versus the snail sort of thing. But it still doesn't tell us what to do. It still doesn't tell us this patient should get radiation because he will do well in radiation. This patient should get surgery. This one should get abiraterone. This patient should get chemotherapy. These are questions that get us into predictive testing, and we are heading that way very rapidly. So some of the recent studies that Decipher has had out allow them to make statements like, if you are getting radiation therapy after surgery, if you have a high risk Decipher, you need to add hormonal therapy to that mix because you're going to increase survival by about 5 or 6% in terms of absolute survival by adding the hormonal therapy. If you're in the same situation, radiation after surgery, and Decipher is low, you should absolutely not get hormonal therapy because overall survival is about 8% lower if you add the hormonal therapy. So, as studies come out that, have real sort of decision point guidance like that baked into the study design, we really get into this personalized medicine era where we're looking at the biology and the genomics, not just to tell us, well, that's a bad cancer, but to really guide us in terms of how to treat that specific cancer.
So when do you use it? Just seems like Decipher, we just got back from the AUA, and I feel like some of those sessions were a Decipher session, not a genomic session.
Yeah.
So when would you use Prolaris as opposed to Decipher?
Yeah.
In what scenario? When would you use? Do you use Confirm MDX in patients that come up negative from their biopsy, just to make sure that their epigenetics is fine?
Yeah, different scenarios. So Confirm MDX, as you say, that's designed specifically for patients who had a negative biopsy. We're looking at methylation in the DNA in the tissue that looks normal to the pathologist to try to predict whether or not we missed a cancer on that first biopsy. But in the post-diagnostic setting, if you go to a research meeting, Decipher is really the story because they have been by far the best academic collaborator out of the companies out there, and they have the most data. There are limits to what you can do with 12 genes or a set of genes in a single pathway compared to the whole genome. So, like I said, Decipher kind of played the long game early on, and even though they were the new kid on the block and kind of struggled as a company, and over the long term, they've survived and thrived, and they've been bought up by Veracyte, and they are really the go-to now. So as a person in academic medicine where I want all this extra data, I basically never ordered Prolaris or Oncotype because I'm getting so much less information. They're not worse tests. For clinical decision-making, I think nobody's ever shown that one is better than the other. I think all three of the companies, in terms of how the tests are formatted, have their strengths and limitations. I don't think any of the test reports is all that fantastic, personally. But for those of us, again, we're talking about centers of excellence and kind of academic centers, we get so much more information out of Decipher that has really become the go-to. Now, that's not a universal statement. I have colleagues at other places that still do a lot of Prolaris testing because they really like the way Prolaris integrates with the clinical information better than anybody else. They explicitly integrate their test with the CAPRA score before treatment and with the CAPRA-S score after surgery, which is the best integration of clinical and genomic information out there. Mm-hmm. So there are other unique strengths with the other tests. But again, in academics, well, this is genomics. This is full genome testing, for no extra charge, really. So that's a huge strength.
All right. I know we are coming close to a hard stop for you, and I want to be sensitive to that.
Yeah.
They need treatment. For for the sake of time, because we could do another hour there. Obviously, it used to be that back in the day there was only two treatment options: radiation or surgery. Period. End of
Yep.
story.
Yeah.
That was the good news. That's also the bad news now, because now there is, like, I don't know, 12 treatment options, and many of those
Yeah.
are focal and things like that.
Yes.
Let's just say they undergo surgery, because we want to stay in this theme of genomics, right? Because you can't
Yeah.
really do genomics in anything else if you're doing radiation or focal, because the prostate is intact still. You remove the prostate. What's the genomic scenario there? Do you send it out for testing? If so, when they take out the whole gland, just for the listener, the whole gland is analyzed for a genomic score. So what's your approach with that?
Well, I mean, first of all, I should say that it's not quite true that we're not using genomics in these other scenarios, because based on the biopsy, if anything, there are more sort of predictive scenarios evolving for the radiation questions. Intensification with hormonal therapy in particular is becoming very clear how we can use Decipher and the Sartera test to try to make decisions about who needs short versus long-term hormonal therapy, for example, for patients on the radiation path.
But on that thought, Matt,
yeah.
How do you know which are the SNPs that are taken and sent to the lab? How do we know? Because I don't know when I order. I don't know what's sent over. Is it all 6? Is it a few of the ones that are positive? And then again, is it missing something else? When you have the actual prostate, you can view the whole prostate and do a
without
genomic
question.
on the whole prostate. Yeah.
Without question. Everything in a radiation discussion or a focal therapy discussion, we're talking about the best possible biopsy we have, and that's what we have. It may have missed something, it may not have. And we know for sure that there are times they get a biopsy that did not represent the whole cancer. We know that by definition, based on how these tests were validated. But they are running it based on all the genes. These are whole gene expression profiles they're looking at rather than SNPs per se. But most of it's based on the Decipher score. They're not yet doing things based on other genes read off the chip, although a lot of that work is in progress. Felix Feng at UCSF with us has published something called a Porto score, which is meant to help guide decision making about radiation after surgery, getting into this surgical question. Based on different genes, we can read off the Decipher Affymetrix array. But that's all still kind of in research mode. As you say, if you take out the prostate, we get the final ground truth on the pathology, and we can definitely find the highest grade area of the cancer to send for genomic testing. We're also heading in the research realm into the spatial omics era, where we're not just going to send one bit of the cancer to look at the RNA, but actually look at what's going on with gene and protein expression in every cell in the cancer, both the cancer cells themselves, the immune cells around them, the background, the stromal cells. This is going to be a whole new generation of insights into the biology, and eventually we'll get a new round of biomarkers out of this to do an even better job guiding
Who's behind that research? What's the name of the company? Or
there's multiple companies, there's multiple platforms. We're doing a lot of it at UCSF. There's a few other institutions. This is still probably a couple of years from clinical prime time, but this is where I think the next generation of insights is going to come from. In the meantime, we can definitely use these tests to guide decisions about, how soon do we need to think about radiation therapy, for example, after surgery. If we're giving radiation after surgery, do we need to add hormonal therapy? Who should be thinking about early chemotherapy? What about an early PARP inhibitor? As the armamentarium of systemic treatments continues to expand, we need to make sure that we are choosing those treatments, which make PSMA PET look cheap, by the way. Which of those treatments should we be targeting to which specific cancers? We need to be getting to the point where we can make those decisions based on biology, not just based on patient preference or on random choice. Histology exactly.
Versus biology.
Exactly.
So when do you send the prostate, if ever, so let's say they get a prostatectomy?
Yeah.
When do you send it for genomic testing, if at all?
Yeah, we'll often do it for those who have adverse looking pathology. We'll send for Decipher. We're also working with a company called Tempus, who will do whole genome sequencing now to really look at the individual driver genes. The two are complementary. So I'll get it fairly often on then with aggressive cancers just to help us get a bit of a sharper look in the crystal ball as to how things might pan out for the next few years. Although PSA is still the big driver of timing of decisions after surgery. But what I will say is if the Decipher is lower risk, I'll let the PSA drift, more, let it drift higher before we think about coming in with the next line of therapy. Whereas if Decipher's high, we've got reasonable data. We really don't want to wait too long in terms of a threshold to pull the trigger on adjuvant or salvage radiation.
Excellent. Dr. Matthew, we call him Matt, Dr. Matthew Cooperberg from University of California in San Francisco. Excellent urology department. It's one of it's when people that travel to places and they go doctor hopping, they say, look, I'm at UCSF with either you or any one of your colleagues, should I come at NYU? Like, you're fine right there. You don't need to go anywhere else. I mean, high academic institution, amazing Department of Urology. Matt, thank you so much for being on and for really enlightened. I'm always learning. I always say I've been doing this for a long time. I'm always learning. Thank you so much. How can people find you, and final words?
Easy to find on Twitter at Dr_Coops, or email matthew.cooperberg@ucsf.edu.
It's not Twitter anymore, Matt. What's wrong with
you?
Oh,
X, yes, of course, X. Yes. I can't do it. Can't bring myself to do it.
It's X, okay. Can you repeat your handle?
Yeah, it's Dr_Coops, C-O-O-P-S, or matthew.cooperberg@ucsf.edu is email. And final words is we are in the personalized medicine era in prostate cancer. It's all about, across the whole pathway, from screening to diagnosis to treatment to downstream observation and follow-on treatments if they're necessary. The mantra really is tailoring the choice and the intensity of interventions to the individual patient and to their level of risk. And that, starts with how do we interpret a PSA, who needs secondary testing, who needs a biopsy, what do we do with the biopsy information, who really should be thinking about observation, active surveillance versus focal therapy versus surgery versus radiation versus combinations of those treatments, and, who needs to be thinking about systemic treatments, early. Our toolkit to guide those decisions is richer and more accurate and more powerful every year. So it's a very exciting time.
If you have to have a cancer and you have to have prostate cancer, this is probably the best time to ever have
it. It's a better time than it's been in the past, that's for sure.
Yeah. Matt, thank you so much. Thank you, everyone, for listening. This has been another great discussion with one of the leading experts globally in this particular area of prostate cancer. So thank you for listening. Hope you got a lot out of it. Remember, thrive. Don't only survive if you're a prostate cancer patient. Lifestyle modifications always help, and lifestyle medicine is real medicine. Much love. I'll talk to you next time. Thanks for tuning in to this week's episode of the Dr. Geo Podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgeo.com. I'll see you next time.